Welcome to the deep dive. Ever wondered what happens when the body's stress response just gets stuck in the on position?
Yeah, it just keeps going.
Exactly. Today, we're tackling Cushing Syndrome. It's this endocrine condition named after Harvey Cushing, the neurosurgeon. Basically, the body's main stress hormone, cortisol, stays way too high.
Precisely. And our mission, you could say, for this deep dive is to really unpack that. What causes this overload? What does it, do to the body? And how do we figure out where it's coming from?
It really highlights how finely tuned our hormones are, doesn't it?
Absolutely. It's all about balance.
So let's start with the basics. Cortisol, we hear stress hormone, but how does it normally work? What's the intended system?
Okay, well, it all kicks off in the brain, specifically the hypothalamus. It releases a hormone called CRH.
CRH, right.
Think of CRH as the initial instruction. It travels just a short distance to the pituitary gland.
Another part of the brain.
Yep. And the pituitary then sends out its own messenger, ACTH.
Okay, ACTH. And where is ACTH off to?
ACTH gets into the bloodstream and travels down to the adrenal glands. These are the little glands sitting right on top of your kidneys.
Ah, okay.
And within the adrenal gland, ACTH specifically targets a middle layer, the zona fasciculata.
Zona fasciculata. Got it.
That's the zone that actually makes cortisol, which is a type of glucocorticoid hormone. It's lipid soluble.
Lipid soluble, meaning it doesn't mix well with blood, which is mostly water.
Exactly. So most of the cortisol that's produced actually grabs onto a carrier protein called cortisol-binding globulin to travel around.
Like a chaperone.
You could think of it that way, yeah.
Yeah.
Only a tiny fraction, maybe about 5%, floats around freely in the blood.
And that 5% is the important bit.
That's the biologically active part, the free cortisol.
Yeah.
That's what does the work. And your kidneys filter out any excess free cortisol.
Okay, so we know it spikes during stress, but what's its day job? It can't just be waiting for panic, right?
Oh, absolutely not.
Yeah.
Cortisol has a very distinct daily pattern, a circadian rhythm.
Right, the body clock thing.
Yeah. Levels are naturally highest in the morning, helps get you going, and they gradually decrease throughout the day, lowest in the evening.
So it's our natural wake-up call, in a way.
In a sense, yes. But beyond that rhythm, during actual stress, it's a master regulator. It cranks up glucose production in the liver.
Gluconeogenesis.
Right. And it helps break down proteins, proteolysis, and fats, lipolysis, basically making fuel readily available.
So it mobilizes the energy stores. What else?
It's vital for maintaining blood pressure. It makes your blood vessels more sensitive to adrenaline and noradrenaline.
Epinephrine and norepinephrine?
Exactly. Helps them constrict properly. And maybe counterintuitively, it actually dampens down inflammation in parts of the immune response.
Really? It dials back the immune system.
It does. It reduces inflammatory chemicals and slows down certain immune cells like T lymphocytes. It prevents the response from going overboard.
Huh. Okay. And I think you mentioned mood and memory, potentially.
Yes, there's evidence it plays a role, though the exact pathways are, well, still being worked out. The brain definitely responds to cortisol.
So it's clearly powerful stuff. How does the body stop it from just running rampant all the time? Keep it in check.
That's the elegance of the negative feedback loop. It's crucial.
Okay, how does that work?
When levels of that free cortisol in the blood get high enough, it sends signals back up to the command centers, the hypothalamus and the pituitary.
Telling them to ease off.
Precisely. The hypothalamus reduces CRH release, and the pituitary reduces ACTH release. Less ACTH means less stimulation for the adrenal glands.
So they make less cortisol.
Exactly. And levels come back down into the normal range. It's a self-regulating system.
Usually.
But in Cushing syndrome, that system breaks down somewhere.
That's the core problem. For whatever reason, cortisol levels stay persistently high. And all those normal, helpful effects of cortisol become exaggerated and damaging.
Okay, so let's talk about those exaggerated effects. What happens when that balance is lost long-term? Well, think about cortisol's role in breaking down proteins. When that's excessive, you get significant breakdown of muscle, bone, and skin major protein smears.
Leading to what?
Muscle weakness, severe muscle wasting, yes.
Yeah.
Thinning of the bones, which we call osteoporosis, making fractures much more likely. And the skin becomes thin, fragile, bruises easily.
Wow. Okay. What about the energy regulation aspect, the blood sugar?
That goes into overdrive, too. You get high blood glucose levels because the liver keeps pumping it out. This makes the pancreas churn out more insulin to try and cope.
High insulin. Does that connect to the weight gain often seen in Cushing's?
It certainly plays a big role. Insulin encourages fat storage, especially in adipocytes, fat cells around the abdomen and the upper back and face. This leads to that characteristic central obesity fat around the middle.
Right, the truncal obesity, moon face, buffalo hump descriptions.
Exactly. Those are driven partly by this high insulin interacting with the excess cortisol.
And blood pressure. You said cortisol helps maintain it normally?
Yes, but too much cortisol makes the blood vessels overly sensitive to those constricting hormones, epinephrine and norepinephrine. That drives up blood pressure.
Okay.
And there's another mechanism too. At very high concentrations, cortisol can actually start to act like a different type of adrenal hormone, the mineralocorticoids.
Which normally handle salt and water balance.
Exactly. So cortisol crashing that party can cause the body to retain sodium and water, pushing blood pressure up even further. It's kind of cross-reacting with the wrong receptors.
Fascinating. So it's messing with multiple systems. What about other hormones?
It can suppress the hormones that regulate reproduction. High cortisol inhibits gonadotropin-releasing hormone, or GnRH, from the hypothalamus,
Which affects.
which then disrupts ovarian function in women, potentially stopping periods and testicular function in men.
And the immune system, you said it dampens it normally?
Right. So with chronically high cortisol, that dampening effect becomes profound immune suppression. This makes people much more susceptible to infections, and wounds might heal poorly.
And maybe effects on the brain, too.
Yes, there can be impacts on brain function, mood, sleep, memory. Again, the exact how is still complex and being studied.
Okay, so this flood of cortisol is clearly bad news. Where does it actually come from? Is it always the adrenal glands acting up?
Not always. We usually divide the causes into two main camps, exogenous and endogenous.
Exogenous, meaning from outside the body.
Exactly. And actually, this is the most common cause overall. It's usually from taking steroid medications long-term.
Like prednisone or similar drugs.
Precisely. These are glucocorticoids, chemically very similar to cortisol. Doctors prescribe them for things like severe asthma, rheumatoid arthritis, other autoimmune or inflammatory diseases.
Because they have that anti-inflammatory effect you mentioned.
Right. But taking these external steroids essentially floods the system with cortisol-like activity.
And does that trigger the negative feedback loop?
It does. The body senses these high steroid levels and tells the hypothalamus and pituitary to stop making CRH and ACTH.
So the body's own cortisol production shuts down?
It often does, yes. The zona fasciculata in the adrenals can even shrink from lack of ACTH stimulation atrophy.
But the person still gets Cushing syndrome. That seems weird.
It does seem paradoxical, but yeah. Even though the internal production is low, the sheer amount of potent steroid coming from the medication overwhelms the system and causes all the signs and symptoms of cortisol excess.
Okay, that makes sense. So that's exogenous. What about endogenous Cushing syndrome, where the body itself is making too much?
Right. Here, the problem originates inside. And the most common reason for endogenous Cushing's is actually too much ACTH being produced.
Not too little, like with the exogenous steroids, but too much ACTH.
Correct. And the number one cause of that is usually a small benign tumor on the pituitary gland itself, a pituitary adenoma.
And when that specific situation happens, pituitary tumor making excess ACTH causing Cushing syndrome, that has a special name, doesn't it?
Yes. That specific scenario is called Cushing disease. These adenomas, well, we don't always know why they form, but they just grow and pump out way too much ACTH, ignoring the normal feedback signals.
So the pituitary is just constantly yelling at the adrenal glands via ACTH.
Pretty much. And both adrenal glands respond by enlarging and churning out excessive cortisol.
Is a pituitary tumor the only way to get too much ACTH?
No. There's another possibility called ectopic ACTH production.
Ectopic meaning out of place.
Exactly. Sometimes tumors in other parts of the body, not the pituitary, can start producing ACTH. Small cell lung cancer is a classic example, though other tumors can do it too.
Wow. So the ACTH signal is coming from somewhere totally unexpected.
Right, and it drives the adrenals, just like pituitary ACTH would.
Okay, so those are ACTH-driven causes. Can the problem start directly in the adrenal glands themselves?
Absolutely. You can have tumors developing right in the zona fasciculata of the adrenal cortex. These can be benign adrenal adenomas or cancerous adrenal carcinomas.
And these tumors just make cortisol on their own?
Yes, they function autonomously. They don't need ACTH telling them what to do. They just produce and secrete large amounts of cortisol independently.
So in that case, what would the ACTH level be?
It would be very low. All that excess cortisol from the adrenal tumor triggers the negative feedback loop powerfully. The pituitary basically shuts down ACTH production.
So you'd have high cortisol, but low ACTH.
Correct. And interestingly, the unaffected adrenal gland, the one without the tumor, might actually shrink because it's not getting that ACTH stimulation.
Mhm.
But the tumor itself keeps pumping out cortisol, so the net effect is still Cushing syndrome.
Okay, it really sounds like figuring out which of these is happening is key. How do doctors diagnose Cushing's and then track down the cause?
Well, the symptoms are often the first clue. We've touched on many of them. The muscle wasting, thin limbs.
Compared to the weight gain in the trunk.
Right. The thin, fragile skin, easy bruising, those purplish stretch marks or striae, often on the abdomen. Bone thinning leading to fractures.
And the appearance changes, the moon face, the buffalo hump.
Yes, those are quite characteristic. Plus, you look for hyperglycemia, high blood sugar, maybe even new onset diabetes. High blood pressure is common, increased infections, poor wound healing.
Menstrual problems in women.
Amenorrhea, yeah. And sometimes psychiatric or mood disturbances too. It's a wide range of effects.
So if the picture suggests Cushing's, what are the first actual tests?
There are a few initial screening tests. One standard is the 24-hour urine-free cortisol test. Collect all urine for a day. Measure how much active cortisol is spilled out.
Okay.
Another is checking cortisol levels late at night, either in blood or saliva. Remember that normal rhythm. Cortisol should be very low then. If it's high, that's suspicious.
Right, the rhythm is lost. What about that dexamethasone test?
Yes, the low-dose dexamethasone suppression test. Dexamethasone is a synthetic steroid, like the ones causing exogenous Cushing's.
So you give a small dose.
Overnight, usually. In a healthy person, that little dose should be enough to trigger the negative feedback and suppress the body's own cortisol production by morning.
But in endogenous Cushing's?
The suppression often fails. The cortisol level stays high despite the dexamethasone. That strongly points toward an internal source of excess cortisol.
Okay, so let's say the test is positive. High cortisol confirmed. Now what? How do you find the source? Pituitary, ectopic, adrenal?
The next critical step is usually measuring the plasma ACTH level.
Okay. And what does that tell you?
If the ACTH level is very low, almost undetectable, that points the finger strongly at the adrenal glands. An adrenal tumor producing cortisol autonomously and suppressing ACTH.
Makes sense. And if ACTH is normal or high?
If ACTH is high, or even inappropriately normal given the high cortisol, then the problem is likely ACTH dependent. Either it's Cushing disease, the pituitary adenoma, or it's ectopic ACTH production from a non-pituitary tumor.
Okay, high ACTH narrows it down to two possibilities. How do you tell those apart?
That's where a high-dose dexamethasone suppression test can be really helpful.
Giving a bigger dose of the steroid.
Exactly. The rationale is that pituitary adenomas causing Cushing disease, while resistant to low doses, might still show some suppression of cortisol when hit with a very high dose of dexamethasone. They retain some, albeit faulty, sensitivity to feedback.
But the ectopic source?
Tumors producing ectopic ACTH are usually completely resistant. They don't care about the dexamethasone, high dose or low dose. They just keep pumping out ACTH and cortisol stays high.
So lack of suppression, even with a high dose, suggests an ectopic source, while some suppression might suggest a pituitary source. Clever.
It's a useful differentiator, yeah.
And then I assume imaging comes into play to actually see the tumor.
Absolutely essential. If Cushing disease is suspected, high ACTH, maybe some high-dose suppression, you typically get an MRI of the pituitary gland to look for the adenoma.
And if an adrenal tumor is suspected, low ACTH.
Then a CT scan of the adrenal glands is the way to go.
What about finding those ectopic tumors?
That can be trickier. If ectopic ACTH is the likely cause based on the hormone tests, doctors might order CT scans of the chest, abdomen, and pelvis, looking for potential sources like lung tumors or others.
Okay, so we've gone through the detective work. We know the cause. How do we treat it? How do we get things back in balance?
Well, it really hinges on that cause. For exogenous Cushing's, caused by steroid meds.
You stop the meds.
You try to, yes, but very gradually. Tapering the dose down slowly under medical supervision is critical.
Why slowly?
Because remember, the body's own adrenal glands have likely been suppressed, maybe even atrophied. Stopping the external steroid suddenly could cause an adrenal crisis, a life-threatening lack of cortisol. The body needs time to wake its own system back up.
Right. That's really important. Okay, what about Cushing disease, the pituitary tumor?
The primary treatment there is usually surgery to remove the adenoma. Transsphenoidal surgery, often going through the nose.
And for the other causes, ectopic tumors or adrenal tumors?
Surgery to remove the tumor is typically the goal there too, if possible. Removing the source of the excess ACTH or cortisol.
Are there medications that can help, maybe if surgery isn't possible or fully successful?
Yes, there are drugs that work by inhibiting the enzymes needed to make cortisol in the adrenal glands. Drugs like ketoconazole or metirapone.
When would you use those?
They can be useful to control cortisol levels before surgery, or if surgery doesn't completely cure it. They're also important for managing symptoms in cases of ectopic ACTH production, where maybe the primary tumor can't be found or removed, or for adrenal cancer that has spread.
So options exist to lower cortisol even if the source can't be immediately eliminated.
That's right. Managing the cortisol excess is key.
Okay, so wrapping up this deep dive. Cushing syndrome is essentially the consequence of having too much cortisol hanging around for too long, whether it comes from outside medications or from inside the body.
Exactly. And those internal or endogenous causes are varied. You've got the pituitary adenomas causing Cushing disease. You've got ectopic ACTH from other tumors, and you've got tumors right in the adrenal glands themselves.
And untangling which one it is requires understanding that whole HPA axis, the feedback loops, and using specific hormone tests and imaging.
Precisely. It's a fascinating look at how intricate our hormonal regulation is.
It really is. It drives home how one hormone getting out of whack can cause such a cascade of effects throughout the entire body. Makes you think about that delicate balance. What other hormonal systems do you think have similarly wide-ranging impacts when they get disrupted? Something for our listeners to maybe chew on.
Oh, that's a great point to ponder. Maybe thinking about the thyroid system, hyperthyroidism, hypothyroidism, they affect metabolism, heart rate, mood, so many things.
Yeah.
Or perhaps diabetes, focusing on insulin and blood sugar regulation, which obviously has huge systemic consequences. It really underscores how interconnected everything is through these chemical messengers.